We know that myeloma cells have a higher level of proteasome inhibitor activity compared with normal cells, and myeloma is a disease producing large amounts of proteins, and this is a disease with greater sensitivity to the proteasome inhibition. So definitely the proteasome has been a therapeutic target, and its inhibition is one of the main cornerstone of the myeloma therapy. My talk at the COMI event will be focused on the use of proteasome inhibitors in the elderly population, in the transplant-ineligible population, but basically proteasome inhibition is across the disease since the newly diagnosed until late advanced stage of the disease. Bortezomib was the first proteasome inhibitor introduced in the clinic to treat our patients with multiple myeloma, and is a boronic proteasome inhibitor of IV or sub-Q administration. In the elderly population, Bortezomib was first combined with melphalan and prednisone, the standard of care for more than 40 or 50 years, and VMP resulted in a new standard of care that has been the most common regime used, especially in Europe, for the treatment of newly diagnosed myeloma patients transplant ineligible. And recently, we had the opportunity to optimize VMP by the addition of daratumumab, the anti-CD38 monoclonal antibody, and dara-VMP is a new standard of care to be utilized here in Europe as well as in US and even in South America and in Asia. Basically because dara-VMP was superior to VMP, not only in terms of progression-free survival, but also in terms of overall survival. And what is important, the addition of the monoclonal antibody did not result in more toxicity. But Bortezomib can be also combined with another standard of care in this population, lenalidomide and dexamethasone. And VRD is another standard of care, also approved by both FDA as well as European Medicine Agency. And this combination can be also utilized in its regular schedule, or maybe we can modify a bit the dose of Bortezomib and lenalidomide according to the RVD light in order to deliver a more convenient scheme for the elderly population. The platform RVD is going also to be utilized to add the monoclonal antibodies anti-CD38, either daratumumab, and the Cepheus study is ongoing, or isatuximab, and there is a phase 3 trial also ongoing. Bortezomib can be utilized in every newly diagnosed myeloma patients transplant ineligible. It works well in patients with renal impairment, in patients even with cytogenetic abnormalities of high risk. But definitely there are other proteasome inhibitors, second generation proteasome inhibitors that can be also potentially utilized. The first one is Carfilzomib. It's an irreversible proteasome inhibitor of IV administration. And Carfilzomib was first also combined with the standard of care melphalan and prednisone. However, unfortunately, the comparison between Carfilzomib MP versus Bortezomib MP did not result in any significant benefit. What is the explanation? I don't personally know. Maybe the dose, because the dose of Carfilzomib was 36 milligrams per square meter. Maybe melphalan and prednisone is not the optimal partner for Carfilzomib. What is true is Carfilzomib has been combined in this population with cyclophosphamide or even with lenalidomide and dexamethasone. Phase 1-2 trials conducted in the elderly population with encouraging results. And what is important, in some of these studies, Carfilzomib was used just once per week, what is relevant and crucial for the elderly population. Professor Ludwig from Vienna in Austria is conducting a randomized trial utilizing Carfilzomib weekly in combination with either thalidomide or lenalidomide in this population, with preliminary but encouraging results, with overall response rate around 80% and 40% of a minimal residual disease negativity rate. The Spanish myeloma group is also evaluating Carfilzomib in the elderly population in combination with lenalidomide and dexamethasone, or lenalidomide and dexamethasone plus daratumumab. So definitely Carfilzomib will be also utilized in this population. The only contraindication for its use is maybe the presence of high risk for cardiovascular diseases or prior medical history of severe cardiac diseases. And the third proteasome inhibitor is Ixazomib, oral proteasome inhibitor, irreversible and also boronic proteasome inhibitor. Ixazomib was combined again first with melphalan and prednisone in the elderly population in a phase 1/2 trial. And unfortunately, and although the results were not very bad, this trial did not move forward a phase 3 randomized study, but Ixazomib was combined also with lenalidomide and dexamethasone. But the news are not very good because, well, we have received a press release this year indicating that the randomized study comparing Ixazomib Lendex versus Lendex did not meet its primary endpoint. What is the main benefit for Ixazomib? I think that Ixazomib, because of the oral administration, can definitely be utilized as maintenance therapy. In fact, in the phase 1/2 trial conducted with Ixazomib in combination with melphalan and prednisone, there was a small cohort of patients who continued with Ixazomib as maintenance, and in this group of patients, although small, the median progression-free survival was much more longer. And fortunately, on November 2019, we received also an interesting news about a press release indicating that a phase 3 randomized study comparing Ixazomib versus placebo as maintenance in the elderly population met its primary endpoint, progression-free survival. The data of this phase 3 randomized trial, the Tourmaline MM4, will be presented in the upcoming ASCO and EHA congresses. So definitely I think that the role of Ixazomib in the elderly population will be basically focused as part of maintenance in this population. In summary, I think that proteasome inhibitors are key drugs in the management of patients with multiple myeloma in general, but in the transplant ineligible in particular. And the good thing is that the proteasome inhibitors can be combined with whatever standard of care, generating optimal combinations. And definitely, as I said at the beginning, proteasome inhibitors were maybe one of the most relevant findings in order to contribute to improve the overall survival of patients with multiple myeloma.